panel discussion, and before that, Gary got his computer working with the videos. I think that's worth seeing. I think Bob has a slide. We're going to have a little debate, Bob and I, in the panel discussion about the importance of plateau pressure. And then we'll start, I'll open it up, obviously, to the whole audience to ask questions and comments. Go ahead, Gary.
Okay, so what we have here is injured lung, unstable. You can see in the lower right, we have a PEEP of 0. Now what I'm going to do is just titrate PEEP so you can actually see. In the second movie, we're going to
like to always have the losing debater go first, so you can go first there.
Yeah, you know, sometimes I get tired as a therapist having to show up these physicians all the time. This is data that was given to me by Len Hudson, who, as you know...
He's a physician, isn't he?
He is a physician. This is true. You know, and I forgave him for that. This is from the original ARDSNet study, in which you have the two groups. Here you have the 12 ml per kilo group and the 6 ml per kilo group. And what they did was plot plateau pressure on day 1 versus mortality of patients at that given plateau pressure. And as I think we've all been saying, pretty obvious, whether you look at 12 or you look at 6 ml per kilo, plateau pressure clearly has a major impact on mortality. The lower the plateau pressure, the greater the probability of survival. Period. End of story. When you put the two on top of each other, it's interesting to note that as you get, as I said, in that 20 to 30 centimeter water plateau range, they essentially overlap each other. That if the plateau pressures were that low in this particular study, it didn't matter which group you were in, your mortality was exactly the same. You take a patient who had on day 1 a plateau pressure at 26, their mortality was about 30%, whether you receive 6 ml per kilo or whether you receive 12 ml per kilo. Now you can argue those patients may have had different levels of lung injury. Obviously, someone who could tolerate a tidal volume of 12 ml with a plateau pressure of 26 had less lung injury than somebody who had a plateau pressure of 26 with a tidal volume of 6 ml per kilo. But nevertheless, as you look at those two areas, there is no difference in overall mortality based on that particular tidal volume. It was the plateau pressure that was the issue, not the tidal volume.
So Bob, maybe we're arguing about different things. The point I was trying to make, and I think that the point of the discussion was, in the range of 20 to 30, that the lower off you are, the better off you are. That's what I was arguing, not that the lower tidal volume, right? Because I agree that if you're at 12 ml per kilo and your plateau pressure is the same as another patient at 6 ml, that same plateau pressure, yes, that makes sense. But the point is, if you even look here on your data, and I'll show you some other data, if I can get this cursor, there we go. If you go for here, it's a decreasing slope. So the lower the plateau pressure. Now that could be based on the fact that those patients at the lower end are less sick. Okay, so that's fair enough. So what the ARDSNet investigators, what actually Roy Brower did, is what I'm going to show you, is this slide taken from a recent paper, and I'm sorry I don't have I just grabbed it off, so I don't have the actual citation. What they did was, and you got to think about this, it's a little complicated in the sense that they didn't have a set way of measuring plateau pressure at time 0. So they measure the plateau pressures while the patients were on 6 or 12. So they then said, well, if we look at quartiles, if we take the lowest quartile, in other words, let's talk about the highest quartile, depending on the way you look at it, the patients who had the highest compliance or the lowest plateau pressures, the quarter of the patients that had the lowest plateau pressures, in each group, 6 versus 12, they should be pretty well matched for severity of lung injury. Right? I mean, you don't know that because it's not prospective, but we're talking, if we had a prospective study, we wouldn't be having this debate. But it seems not unreasonable. You have 800 patients, you take the quarter with the lowest plateau pressure, you match them with the other quarter with the lowest plateau pressure. That seems to me a pretty reasonable match. Before randomization. Exactly. So if you look at that, and now you look at the mortality, the patients who went on 6 ml per kilo had lower plateau pressures, compared to those at 12, and yet they had a much lower mortality, sort of 34 to 24. So the point there is that it'd be better off, somebody would be better off, instead of being at a plateau pressure of 29, if you could get them to a plateau pressure of 22, the same patient, that would likely lead to less mortality, suggesting that ventilator-induced lung injury occurs even within that range which we consider quasi-safe. So that was what I was arguing. And actually the data that I think someone mentioned about Rolf's study, the prospective study in relatively normal patients, not normal patients, patients without ARDS who get into the ICU, who develop ARDS, that it's more likely to happen if you're given a higher tidal volume than a smaller. Given that they don't have ARDS to start with, my guess is that even though the plateau pressures weren't measured, they'd be nowhere near 28 or 30 or even 25 during that early in the course. So I guess that the point here is that lower plateau pressures are better if you could, and then there's a trade-off. There's all sorts of other reasons you may not want to use low plateau pressures, but according to these data, I think being at a lower plateau pressure is better for patients. And that argues, for example, some people have said, well, use pressure control of 30, forget about 6 ml per kilo. But it seems to me if you use pressure control of 30 and the tidal volume is 9 or 10, you're not as good off as being at a pressure at 6 ml per kilo with a plateau pressure of 22 or 23.
But I think the important message is what both of us are saying. Tidal volume is not the issue. It is plateau pressure. And you should strive to get a lower plateau pressure, irregardless of what tidal volume that patient is actually receiving. That 6 ml is not a magic number, you know, and you need to focus on a lower plateau pressure more so than focusing on a particular tidal volume.
Yeah, I think how to do that is a question, so we go with 3 or 4, but yeah, and of course we all agree it's not really plateau pressure, it's probably the transpulmonary or the transalveolar pressure. John?
I think that last point is incredibly important. In the ARMA trial, they did not paralyze their patients. You know, they were all basically spontaneously breathing. So even a plateau pressure of 28, if you were on pressure control ventilation and you're breathing, then that could be associated, especially if you were labored breathing, with a much higher transpulmonary pressure. And if you paralyze those patients to the same tidal volume, you may find their pressure, their plateau pressure suddenly leaps from 28 to 42. The important point here is it's not just plateau pressure even, it's a plateau under controlled conditions, similar breathing conditions. Otherwise, inferences are not.
I guess the converse to that, before Bob, the converse to that is patients who have a very stiff chest wall with massive ascites, for example, keeping them arbitrarily at a plateau pressure of 30 could easily be detrimental. More atelectasis, more hypoxemia. In those patients, you can liberalize that plateau pressure. You're not going to, well, you're going to have less propensity for ventilator-induced lung injury. Bob?
Yeah, I just want to reiterate the point that John made in his presentation. In that patient he described, the best thing we can do is make sure that our approach to ventilating that patient results in a decrease in the ventilatory demand of that patient. It may be that you've kept this patient in volume ventilation at 6 ml per kilo tidal volume, and that patient is fighting to get 8 ml per kilo tidal volume. By changing the way you ventilate it to allow that, you may completely alter the transpulmonary pressure that the patient develops, or the way you set the ventilator, or the amount of sedation. To leave patients struggling with ARDS, I think, is a problem. And it doesn't matter what approach, what mode you use to mechanically ventilate. Those patients who are huffing and puffing away and who you can visually look at and perceive by their appearance that they've got to be developing significant transpulmonary pressures or significantly negative intrathoracic pressure, I don't think that we're doing those patients a favor.
Comments, questions from the audience? Let's get the microphone if you don't mind.
I like the plateau pressure a lot, but I think the other salient point that I'm really taking home from this is not just plateau pressure being significant, but from patient's eye time can be very, very, very protective. And the combination of using these two techniques, the plateau pressure, which we use at my institution, but in addition to proper sedation management and prolonged eye time, can maybe have a very complementary effect in the long run. And perhaps both of those combinations can show even a greater reduction in acute lung injury related to ventilator.
How long eye time are you thinking about? Percentage-wise, what eye ratio are you thinking about? I think about inverse ratio ventilation or within sort of the non-inverse ratio range.
We're more traditional, but we like to use 1.2 seconds or longer. We try to stretch it out as long as we can, and we kind of use use a PRVC mechanisms for our volume control patients. If we're not pressure controlling, we use a kind of a PRVC modality.
Could I step in and just say that I would caution that the patient should be fully recruited if you're going to extend the inspiratory time. According to the data that I just showed from Michigan, the longer you extend that inspiratory time at high stress, the more likely it is that you're going to damage the lung. So the high stretch period, if you have many interfaces that are at risk, could actually be a detrimental strategy. So again, it ties into recruitment and trying to minimize the stresses on the lung.
And my assumption on your comments were that you increase inspiratory time as a means of elevating mean airway pressure to improve oxygenation. Is that correct? Or to enhance patient ventilator synchrony? You know, your reason for lengthening inspiratory.
My approach is I'm trying to target my alveolar units with longer time constants. So I try to take in my more sedated patients that have minimal diaphragmatic activation during their ventilation. My approach has been for years to recognize that I have distal lung units that are generally not recruited in shorter time constants. So I need to extend my time constants over a period in order to try to recruit them. So that's my general approach towards them. But Dr. Marini, as you had mentioned, I'm looking at both of them together, not one as opposed to another. We are believers, I'm a total believer in lung protective strategy protocols. We've implemented those in our facility. We certainly look at plateau pressures, absolutely, and that's part of our protocol. But I guess that's a secondary point that I find really impressive about part of the second half of the lecture series is that time is really important. And I've always felt like shorter eye times do have an effect, and I'm now seeing that, anecdotally I've felt that way for years, but now I'm seeing a lot of literature to support that shorter eye times are associated with increased lung injury, and I'm guessing that there's a lot of violence that takes place in terms of thousands and thousands of peak pressure changes per day in the lung of a patient.
Well, yeah, I don't think there's any data that has been, published in studies where lengthening inspiratory time compared to setting in a similar level of mean airway pressure using positive and expiratory pressure has resulted in any difference in outcome, whether you look at animal data or you look at human data. Clearly, you'll find case series that demonstrate that lengthy inspiratory times, inverse ratio ventilation produced good outcome, but they were case series. When there has been comparisons using very similar strategies, but one applying PEEP, one increasing inspiratory time, there have been virtually, no differences in the ability to oxygenate. Now, no long-term, outcome studies. One of the problems you get into as you look at an open lung approach to ventilation is that you're going to have a very small driving pressure. And in order to maintain, in some patients, some even reasonable level of ventilation, you're going to have to increase your respiratory rate. So by virtue of that, you either have to accept one or two philosophies: inverse the IE ratio, or to use a short inspiratory time to allow you to achieve a rate of 30 or 35, per minute. We have, and I'll let the others speak for themselves, have chosen the shorter inspiratory time in order to allow us to, ventilate that patient. And long enough time to allow airflow to go to zero if you're using pressure control ventilation as you described, but beyond that, in my assessment of the data, I don't see information that would support further increasing that inspiratory time from a gas exchange perspective. And at the small times we're talking about, I don't think they fit the experimental data. If you're talking about 1 to 1.5 seconds, I think that's not an unreasonable time for some patients, but maybe an unachievable time in others if you look at your ability to get rid of CO2.
We talked about a lot about recruitment maneuvers during the day, and I wonder, Fernando, tell us a little bit about the practical issues. How long does it take you to do the maneuvers you do in your patients? What are the effects on hemodynamics? How do you make sure the patients are stable? Do you have to fluid load them? Give us some practical issues in relation to recruitment maneuvers.
Well, I can keep talking for a long time explaining this. Usually we have introduced it in our routine, so it's quite. It's kept in a quite practical way. So, of course, the patient has to be hemodynamically stable, and the key issue here is that he has a good volume status. And I think the new ways of looking at the functional hemodynamical status with the systolic pulse variation issues are very much applicable to this type of interventions in the lung. So we want to have the minimum systolic pulse variation before we even start to challenge the lung with increases in pressure.
So, Fernando, what does that mean? Do you fluid load them?
Yes.
How much fluid would you give them?
Well, it depends. So we first challenge the lung with a modest increase in pressure and see the response. And if we have the major swings in the pressure tracing, then we start giving volume until we correct the swings.
And what can you give us a range or what the highest value would be?
Well, it's usually not too much. Of course, we
have you ever given more than a couple liters, or more?
We start thinking of recoupment when the patient is already stable. So it's not that we have a patient that is in the reanimation phase after intubation or after admission. So the patient has gone through this phase and has received already some volume, and now what we want to see is the cardiopulmonary interaction, to see how it's going to tolerate the increase in pressure. So at that stage, we usually don't need too much fluid. And I would say that as a rule of thumb, we have to administer 500 mLs to rarely 1 liter.
Okay. And how long does it take to do the whole ascending and descending, or specifically what you do?
Well, not so long. The recruitment pressures are applied for 2 minutes. And then the decremental peak trial, we follow the changes in compliance, and we wait until we have a stable signal. This takes about 3 to 4 minutes on each step. And then when we identify the maximum value, we don't go any further. So this could happen very, very soon if the patient is sick with high levels of PEEP, or luckily if he's in a much better condition, it takes longer, but then we can actually identify a much lower level of PEEP, and that takes then like 20 minutes or 30 minutes. The good issue about it is that from that intervention, you learn about the condition of the lung. You identify the recruitment pressures, the PEEP level that the patient needs, and then you set your ventilator, and then later on, you have a new opportunity to take a look at the condition, if it has improved or not.
So let me ask you a clinical question now. There's a lot of talk about aggressive recruitment maneuvers and high PEEP. and everybody agrees we need a clinical trial to address that. Is it at the stage where you think, well, the panel thinks we should be doing this in the 20% of our sickest patients? Forget all patients, because I think everybody agrees in your non-sick patients you won't. Do you think it's ready now for prime time, or do we have to see those data? Because there are detrimental effects. Bob?
Well, I mean, it's always difficult to categorically recommend, a strategy that has not been proven in a randomized controlled trial.
This is not, by the way, this is not a take-home message. This is what you have to do. But just in terms of people's gestalt, because there aren't data. But
my own bias is that we need to apply lung protective approaches to ventilation from the very minute we begin ventilatory support on patients. Those patients particularly who have the greatest level of lung injury, the lowest PF ratio and the highest FiO2 requiring high levels of PEEP, I think there's enough data that would imply that doing lung recruitment is safe. Now, in saying that, you heard what Fernando had to say. You had to very carefully ensure that the patient is stable. They have to be, fluid loaded to ensure that you don't have wide variations in pressures as you begin to elevate your ventilating pressures. As you look at the data that Amato, the study we talked about, there was clearly some drop in pressure, but not a significant drop that required the recruitment stopped in any of those patients. In those 26 patients, one patient developed subcutaneous emphysema at 12 hours after the recruitment procedure and one 2 days later. So that the negative side effects at the bedside are minimal. Even the ARDSNet in their trial evaluating lung recruitment strategies that was published in Critical Care Medicine a few years ago, it was a negative trial, but there was no hemodynamic problems. They had no reported pneumothoraces in any patients that they studied.
But those are pretty wimpy recruitment maneuvers compared to what we're talking about here.
Well, it was 40 centimeters of water peak pressure. We're talking about using a peak pressure between 40 and 50 is what I would recommend. So
not go to 60?
On a routine basis. I think it's safe from what we know today based on the studies that have been published to do 40 to 60. Or
so
excuse me, 40 to 50 centimeters.
Would you do that as opposed to putting the patient prone?
Personally, yes. I think proning a patient is involved in a lot more difficulty. Anybody here who has proned a patient, it's not an easy thing to do. You lose airways, you lose vascular lines, et cetera. I think that the negative side of doing a lung recruitment maneuver is less than the negative side of proning a patient. Now, that's my philosophy on it.
John.
I generally agree. But I think there are other elements of proning that are helpful, and we've gone over those ad nauseum and before, and I can see the audience has nauseum, so I'll mention recruitment is part of it. The regional recruitment is important. The evening of the distribution is important. When you're dealing with a patient who otherwise would require fairly dangerous alveolar pressures to apply, I would go first to proning. We've done in our institution for as long, I think, as Bob has, or maybe not quite as long, 15 years or so, and we have a trained group of people who can do it.
Well, Bob's done a lot longer. He's a lot older than all of us, right?
Oh, yeah. The lymphatic drainage is probably a little bit better in the prone position. The airway drainage is better in the prone position. The evening of the transalveolar pressure is better, so you have a better handle on what a plateau pressure is doing in the prone position. I don't think they're mutually exclusive. If someone is recruited aggressively, gets to a PEEP level that's satisfactory, they don't have a drop in blood pressure, they can be maintained in a supine orientation as long as you're satisfied with what the patient is doing and clinically seems to be responding to your treatments. Otherwise, I would go early to the prone position and recruit in the prone position.
So, John, if you have a patient, after you've initiated ventilation the first few hours, is you immediately prone at that time?
No, Bob. I would try the recruitment maneuver just as you do first, and it would be a recruitment maneuver that would not be the 40-40 maneuver that we used to use. It would be a pressure control strategy like Fernando was describing, or like just simply raising the PEEP level above 25 centimeters of water and letting the peak inflation pressure get to 50 centimeters or so. That would be okay.
And I agree 100%. So that if that worked and you could maintain this patient on a reasonable level of PEEP and you could drop the FiO2 to 40 to 50%, would you consider proning?
I would consider it, but I wouldn't think it mandatory at that point.
And I would agree with you that if that didn't work and we had tried a couple more recruitment maneuvers, then I would consider prone. Because I think proning is, in my opinion, more difficult than doing the recruitment procedures.
Yes.
Comment from the audience, a question?
Yeah, maybe one of you could comment on the use of end-tidal CO2 as a measure of recruitment or adequacy of recruitment. Is it the way that primarily increasing end-tidal CO2 would describe, better ventilation perfusion ratio, but until some point that you could go across the limit the way that end-tidal CO2 then starts to decrease as a sign of increasing dead space ventilation. Can you use end-tidal CO2 when it starts to decrease as a sort of safe limit in terms of recruitment?
Yeah, I think end-tidal is useful, but I think always in the combination with the arterial PCO2.
Precisely, yeah.
The gradient. We have seen many times that with the recruitment effect, we have a very big reduction in the difference of the arterial to end-tidal CO2. And this changes, if we go through the whole PEEP titration process, for example, it parallels exactly the behavior of shunt. So we have, with this parameter, another way of monitoring the changes that are occurring inside the lung. So I think in combination with PaCO2, it's a very useful parameter to follow.
Could I just chime in and say that when Luciano looked at his proning data and looked for the difference in mortality between groups, those patients who on first proning had a reduction in arterial CO2, indicating recruitment, better gas exchange efficiency, had a lower mortality rate, and that paper was published a few years ago. So I think expiratory CO2 dynamics are important, not just end-tidal, but maybe the whole curve, as I think Fernando showed earlier.
Mm-hmm. So if I can ask Fernando a question. Based on your previous presentations, I got the impression that the compliance, dynamic compliance, was the most useful, easiest to apply bedside tool to use to adjust PEEP level post-lung recruitment. Are you saying we should add end-tidal CO2 to that? And do they coincide? Are they changing as rapidly? I mean, from a practical perspective, I agree with your concept of using compliance, that based on our data, both patient and animal, you get very rapid equilibration and very nicely choose the proper point.
Well, I think the process is complex enough that the more information we have, the more angles that we look at the behavior of the lung, the better. And regarding your question, it's a useful parameter, but don't forget that it's also invasive. You need the PaCO2 at each moment. End-tidal CO2 alone is not giving you much information. So if you use compliance, you have a parameter that is available on a breath-to-breath basis. There are other parameters, like I showed today, the changes in the slope, maybe there is a signal in the single breath test of CO2. And I think that's a fascinating, very much underused monitoring in the ICU. And I think the story with CO2 is has still a long way to go, and we will learn much more as we challenge the lung in a more aggressive way.
Any other questions? Question back here.
I have sort of a comment question. It gets back to the practical aspects of the recruitment maneuver. We have an institution, about 400 beds, anywhere between 20 and 30 ventilators at any given time. And I was having a discussion last week with the director at Herman Hospital in Houston, which is a much larger facility, about 1,100 beds, 70 to 80 ventilators, 20 to 25 therapists at any given time, with varying skill levels. To expect these recruitment maneuvers to be done uniformly across the patient population, it's a great concept to spend 45 minutes with each of these patients doing this. But in the practical day-to-day operations of a large department, it's very difficult. Now, their answer is they're working with their vendor, which I won't mention the name, to bring back the PSI as the poor man's replacement for doing recruitment maneuvers. Do you see any value in that approach?
Who wants to address that? Bob, you want to address that?
Well, let me take your second comment first. There are two studies that I'm aware of that have used PSI and that imply improvement in oxygenation. Both Italian studies, one that looked at relatively stable patients who are on pressure support, and adding a one PSI per minute clearly improved their oxygenation, stabilized their lung volume, but they weren't the kind of patients we're talking about. Then a secondary study from Luciano Gattinoni's group that looked at patients with ARDS, in which they started out with 1 hour of conventional ventilation, and then 1 hour where they added PSIs, and then 1 hour back to conventional ventilation. The 1 hour adding PSIs, they went to a peak pressure of 45 centimeters of water. During the PSI maneuver, they did 3 maneuvers per minute, and then went back for an hour and evaluated, the patient without PSI. They clearly noticed an improvement in oxygenation. However, the PO2 changes were in the range of going from 80 to 90 to 120 to 130, nowhere near the type of changes that we're talking about. But the more important issue that concerns me about potentially using a PSI, we are concerned about applying pressures of 40 to 50 for 2 minutes during a recruitment maneuver. You PSI a patient 1 or 2 or 3 breaths every minute, every hour, every day. The cumulative effect, as John said, on potential lung injury, we do not know. There is no data that I'm aware of, either laboratory or patient, that would define that. And we can all figure it out how many breaths that would be if we maintain that for an hour or two, and does that result in lung injury in those patients? I would presume yes, although the data is not available.
John?
I'd just like to make a brief comment for a change.
Sure, John.
If you recruit and return to the same level of PEEP, the likelihood that you're going to retain what you just recruited is poor. It's not impossible, but unless you have a very special type of lung injury, it's not going to stay open if you return to the same level of PEEP. The PSI recruits, but then you probably need a higher level of end expiratory pressure. If you get a response to a PSI maneuver, usually you're operating at an under-recruited lung. Because in the studies that we've done experimentally and at the bedside, and others have shown, if you've got a surfactant depleted lung, a lavage kind of situation, yes, you can retain the oxygenation benefit after a recruitment maneuver, returning to the same level of PEEP. But in almost every other circumstance, the lung collapses again. So if you're going to use size, it probably is telling you, and you get a response, it's probably telling you need more PEEP.
And my comment is that the issue is not the improvement in gas exchange. The issue is protecting the lung. So if you apply a size with the intention to have a better blood gas at the end of the day, this is a wrong approach, because you're getting to this situation by probably injuring more of the lung. And I think when you apply a lung protective strategy, as just John Marini said, and you take your time to select the PEEP, you're able to stabilize the lung on the long term, and that's exactly what you want. Not to mess more with the lung, try to minimize the number of times you have to recruit it, and try to maintain a stable condition as long as possible.
Any more comments, suggestions? We're nearing the end of.
My question and or comment is plateau pressure is, I see it more as a predictor of mortality. When Bob came back from lunch, he showed a couple of lines on a piece of paper, and the last bar graph that was on the screen aped that data pretty much. The 20 to 30, 6 to 12 milliliter data showed about the same percent of mortality. Plateau pressure isn't something that happens clinically more often than a person performs a test to make a determination. It's not a minute-to-minute thing that occurs. That's what I'm curious as to why this is our focus when it's not something that happens to the patient on the ventilator around the clock.
Go ahead, Bob.
Well, I think we've made it a focus because every one of us believes this is a very critical issue in managing these patients. The other thing that allows you to be able to monitor on a breath-by-breath basis what your plateau pressure is by using pressure-targeted ventilation as opposed to using volume-targeted ventilation. If I use pressure-targeted ventilation, I know my plateau pressure can never be higher than what I set my maximum airway pressure. So I can avoid the complex problem of trying to monitor plateau pressures on a regular basis by ventilating with a mode that prevents me from exceeding a particular plateau pressure level. So my bias is that you can accomplish the same thing with pressure-targeted ventilation as you can with volume-targeted ventilation, particularly if you're focusing more on trying to reduce the plateau pressure than you are in trying to target a tidal volume.
So that sounds simpler, Bob. Would you then monitor tidal volume, and if it goes up really high, decrease? And secondly, again, the issue is, though it's simple, patient breathing spontaneously.
Well, again, getting back to what we said before, you need to monitor the patient carefully so the patient is not overly stressed if you're allowing them to breathe spontaneously. If the patient is not breathing spontaneously, it's pretty amazing how constant your tidal volume is in pressure-targeted ventilation. If they're sedated, you don't have much variation in tidal volume on a moment-to-moment or even an hour-to-hour basis. If they're breathing spontaneously and you have corrected their excessive ventilatory drive with appropriate sedation, setting of the ventilator, etc., you're going to see variations in tidal volume, but not great variations on a breath-to-breath basis.
And you would pick that target aimed at a 6 ml per kilo? How would you pick that target?
Clearly, it's patient dependent on how that patient falls out as you're managing them. One patient can have 15 a PEEP, another patient can have 20 a PEEP. In order to try to maintain an acceptable level of ventilation and an acceptable pH, you're going to have to choose some level of plateau or some level of ventilating pressure and subsequent tidal volume that seems acceptable. If you cannot achieve a reasonable tidal volume delivery with 25 centimeters of water peak pressure, you're going to have to go higher. As I said before, I would gauge what tidal volume I would consider acceptable based on what plateau pressure was actually being achieved during ventilation of that patient. The higher the plateau pressure, the lower the tidal volume I would accept as an acceptable volume in ventilating that patient.
Any other comments on that? Well, I'd like to thank, if there are no more further questions, I'd like to thank the speakers for great talks and great discussion.